All right. Welcome. Nice to see some of you guys. I'm Andra Farkas. Oh, okay. And I'm having trouble with PowerPoint. I'm Andra Farkas. I'm one of the EMS docs at the University of Colorado. Do medical direction for a couple agencies out in Eastern Colorado. Good to see you guys on there. And thank you for coming to our rural EMS education series. Like I said, don't forget to email Ryan to get your credit. I'll be talking about pediatric EMS considerations. And thank you to a couple people who helped me put this together. One of them being Brian Peltz, who is a ICU PA who did peds for a while and let me borrow a little bit of content on burns and trauma. A little bit of caveat before we get started. I am an ER doc and an EMS doc. I am not a peds doc. And if there are two things that really scare ER docs, it's kids and pregnant women. So I try to talk about these subjects as much as possible because they do scare me and I want to learn more about them. And then certainly I do not have any disclosures. The way we'll do this is we'll do a bit of an anatomy and physiology review first, and then we'll do a couple of cases. I'm going to turn my camera off, but I promise that is only because my computer struggles with PowerPoint, Zoom, and camera, but I am here, I promise. All right, so let's jump right in with a quick A&P review. So obviously we know this, but just a reminder that kids are not just little adults, right? That's the whole point of this anatomy and physiology review. There's a lot of differences and they start with the vital signs. You guys know this. We all know that their heart rate and their respiratory rates are a lot faster and their blood pressures are a lot lower. It's not abnormal for an infant to be breathing, 40 times a minute, 50 times a minute. Whereas as you get older, obviously that slows down, same with the heart rate. And the hypotension, the blood pressure is always what throws me off. And I always have to refer if I see a kid, because I have to remember, like, is 70 low for this 12-month-old, or is this actually normal? Obviously, I will defer to whatever resources and protocols your agency uses. But definitely, there's a lot of good resources out there to look for pediatric vital signs. I don't memorize things. And so you can easily look that up. From top to bottom, there's a lot of differences between kids and adults, right? Kids' heads are a lot larger, especially in relation to the rest of their bodies, which means two things. They both have more relative mass, which means that when they fall, they lead with their head in a fall. So that's kind of where their center of gravity is. They also have a lot more surface area in their heads. So they lose a lot more heat through it and also more like insensible losses. So if they sweat, they lose a lot more fluid basically that way. And this is especially relevant in burns and falls, of course, with the mass. When they're supine, meaning laying on their back, their heads are large. So they cause their neck to kind of flex upwards because, their heads are so big. And this is quite relevant for two things, both for cervical spine and for their airway. Their brains in general have smaller subarachnoid space, so that, that cushioning between the skull and the brain matter. So there's less of a cushioning effect. Higher concern for bleed if there's more minimal injuries, something like, head momentum and stopping is concerning for the neonates, the really young ones. It provides that concern. There's also more blood flow to their brain. So there's an increased risk of hypoxia causing more damage, even minimal hypoxia, because their brains are used to getting so much blood flow as they're growing, developing, etc. They're moving down, their necks are shorter, right? So the approach to the airway is quite different in kids compared to adults. They have a small mouth and they have a large tongue, which kind of tends to get in the way. Their airway, their larynx specifically also is more anterior, so more forward, and more superior, so higher up. So it's really harder to get to when you're trying to intubate a kiddo, certainly depending on age, but especially the younger ones. Their airways are also more narrow, so they're more prone to obstruction. They're more prone to getting a grape stuck somewhere in there. Their epiglottis, which is, that covering that protects your airway from food stuff and all that other stuff, it's a lot floppier. So when you're intubating, for my paramedics out there, it's, you have to kind of get that epiglottis out of the way, and it's a bit more challenging. Sometimes you have to lift it with a straight blade rather than try to get into the area above it and lift it that way. They also have shorter tracheas. So when you are intubating a patient, it's a higher risk that it'll be a right main stem because it is so much of a shorter space in the trachea, but it's also a higher risk of an inadvertent extubation when you're moving a patient that's intubated, for example, because there's so much little space in that airway. From a respiratory standpoint, when we're talking about infants, they are what's called obligate nose breathers during the first few months of life. So they have to breathe through their nose. So if they get their nose plugged up with mucus or something like that, then it can really cause them respiratory distress. They're not breathing through their mouths as well. They're also belly breathers. So they use their diaphragm to breathe more than their chest muscles. So any pressure on the abdomen, like from trauma or what have you, can really lead to respiratory compromise. Their airways in general, much like their trachea, is much smaller, and are much smaller, excuse me. So that means there's more increased resistance when you're trying to oxygenate and ventilate. Their airways also have less cartilage, so they're a lot floppier, meaning that they're more prone to collapse with smaller insults. They also have more mucus cells, so really they're making a lot more secretions. And then they also have these immature cilia, which are the cells in the airways that will, bump up the mucus and move it upwards. These are immature, so they're not working as well. So they're not clearing their mucus quite as well. So put that together with the obligate nose breathers, and you have really challenging airway situations or breathing situations. Because they have a higher, or not because, but along with the fact that they have a higher respiratory rate, they also use more oxygen. So their metabolic oxygen demand is higher. So they're at risk for inhalational injury if they're in a fire, for example. And also it means that hypoxia is a very much bigger of a cause of crashing, so bradycardia, cardiovascular collapse, etc., in kids than it is in adults. So we really need to treat oxygen problems in kids. When we look at their hearts, they have, or the cardiovascular system in general, they have a larger circulating blood volume. So basically they just have more blood per kilo of weight than adults. And what does this mean? This means they really keep their blood pressures for a lot longer when compared to adults when they're in shock. So you really have to suspect shock in a kid with much earlier signs, maybe just some tachycardia and maybe some, perfusion issues. Because if you wait until they're hypotensive, then really they're on the verge of collapse. Kids, specifically in trauma and hemorrhagic, can lose like 40% of their blood loss, or their blood volume, before they even show hypotension. They really depend on that heart rate to compensate for their cardiac output. So you really have to kind of have a high suspicion for hypotension and shock in kiddos. And like I said, a reminder that a lot of most pediatric arrests are from hypoxia, unlike a lot of causes for arrest in adults. When we looked at their abdominal organs, they're generally more anterior, and then their abdominal wall is less developed, and they tend to have less subcutaneous fat, which all to mean in trauma, they're at risk for, viscous injury or injury to their abdominal organs, more so than adults. By the time they reach about 35 kilos, they kind of tend to have an adult structure, but in those first couple of years, they're certainly at higher risk. And then finally, their bones are a lot more pliable and bendy. So with like thoracic trauma, for example, instead of a rib fracture, they're more likely for the ribs to bend in and have pulmonary contusions rather than a rib fracture like we'd see in adults. They also have very different fracture patterns. And when we're talking about the bones in their neck, so the cervical spine, there's a little bit of a difference between adults and children in the location of the injury. So for kids, it's usually in the upper cervical region, so from like the skull to C3, because they're like fulcrum of motion, so that like that point of where they bend is like C2, C3. In adults, it's a lot lower. It's like C5, C6. And so you can have a lot higher of cervical spine injuries in kids than adults. You can also have this thing more commonly in kids called spinal cord injury without radiographic abnormality, which is really just a term that talks about kind of like some clinical signs of spinal cord injury without evidence of fracture or any abnormal alignment on radiographs and CT. It can happen in adults too, but much more common in kids, especially with their bendy bones and their higher level of bending. Any questions on any of that, on the boring stuff, before we jump into some cases? I have the chat open, and feel free to also unmute yourselves if you have any questions. Awesome. All right, case 1. We have 5 cases to go through. I would love for you guys to participate, whether typing or unmuting. So your dispatch is an MVC rollover on a county road. This never happens in rural EMS, right? Nobody ever rolls their car over. Took a turn too fast, flipped, turned multiple times. There's 4 kids in the car, 3 are hurt, maybe a 4th, maybe someone got ejected. It's kind of unclear. There's a lot of chaos. The RP reporting person is very chaotic with dispatch, so it's a little bit of limited information. As you were driving there, as you're kind of getting ready to go, what is running through your head when you hear this? What are your first thoughts? PG? What's PG?
Yeah, my first thoughts are not PG rated.
Oh. Yes.
Oh God.
Curse words. Got it. Yes. MCI triage, patient age, and need more help. Yes, exactly. Call for backup, right? If there's 4 potential patients, and call the chopper. Exactly. Those were the 2 main things. Other thoughts, is the helicopter flying that day? Is the weather crappy and they can't, fly out there? What's your closest facility and what can they handle in terms of this, right? Is 4 patients going to completely overwhelm their system? Then it's an MCI, right? Mass casualty incident. What's the closest trauma center, right? Realistically, out there, probably pretty far. What about pediatric trauma center? Probably a lot farther, right? A lot of these factors are kind of what go into as you're kind of preparing for this and thinking about these transport decisions, very individual systems based, right? Peds Trauma Center, exactly, based on what resources you have and how far away they are and how easily accessible they are. I'm going to review 2 articles briefly that kind of talks about this. This is a study that was published back in 2021, looking at pediatric mortality at pediatric versus adult trauma centers. You said Peds Trauma Center, Steve. Caveat, the data is from like 2011, 2012, so it is a little bit older. But basically, they did a retrospective analysis. So they looked backwards at some severely injured kids, so patients under 18 with pretty high injury severity scores. Yes, what time of day and how many people are around? Definitely a huge factor too. Thank you, Kevin. They stratified the subjects into 2 age cohorts. So kids less than 0 to 14, and then adolescents 15 and up, and looked at 10,000 children who were injured. So over 1 year. They did some confounder adjusting and did some fancy math. I don't really fully understand it. But basically what they found was that kids who are 14 and under had lower odds of either emergency department or inpatient mortality at pediatric trauma centers when compared to adult trauma centers, which, it's not surprising for anybody, right? Pediatrics are different branch of medicine, and pediatrics trauma surgeons are super specialized, et cetera. When they looked at adolescents, so the 15 and up, there was actually no differences. So this kind of guides a lot of our thinking about what age cutoff goes to a pediatric trauma center versus can go to an adult or regular trauma center. There was another study that looked at outcomes in severe pediatric trauma again, but this time they just looked at adult trauma centers and they looked at differences in trauma case volumes. So basically they looked at all severely injured pediatric patients that were treated at an adult trauma center They did the National Trauma Data Bank. They stratified the centers into 4 groups based on their overall pediatric trauma case volumes, right? So lowest group with the lowest numbers per year or whatever, and then the highest group number 4 that had the most. And they looked at the mortality rates of the pediatric patients. This one was a bit smaller, it was like 3,700 patients, but no surprise, the highest volume centers had the best mortality. So again, when you have experience with taking care of pediatric trauma patients, those patients tend to have better outcomes than if they're taken to a facility that doesn't. But I mean, that's nice, right? When you're doing urban EMS, where your transport time maybe an additional 5-10 minutes, right? I work across the street from a pediatric trauma center. So that's really nice and good when you have those access, but it's a little bit different in the rural community. So back to our case. This is your scene. There's a 16-year-old who was driving. There's a 15-year-old in the front. And then in the back, there was an 8-year-old and a 5-year-old. Insert more non-PG words here, right? Take it one at a time. So the 5-year-old was helped out of the car. When you first look at him, there's evidence of head trauma, and you're seeing a lot of blood all over the place. Primary survey, the airway is intact. There's equal chest rise bilaterally. Kid is breathing pretty comfortably, maybe a little scared. There's a large scalp lac that is bleeding actually quite profusely. And when you go to feel for pulses, a little bit thready. Kid is awake, but anxious and confused, and pupils are equal round reactive. And then there's no other signs of trauma. What's your next move? What are you worried about with this kid? What's your approach? Sick or not sick? Sick, right? Stop the bleed, oxygen, really sick. Yeah, absolutely. Yep. So I'm concerned for hemorrhagic shock, right? If you see a lot of blood, remember all the like 5 places where you can lose blood and one of them is on the street, get flight going. Yeah, oh my gosh, absolutely. This kid is concerning for hemorrhagic shock. So you want to stop the bleed, and I mean, harden a 5-year-old, but try to get IV access. And if he really goes down, then IO is definitely an option, right? This is a classification of hemorrhagic shock in children. The actual classes are not important by any means. I memorized this only for exams and residency, but we don't have the vitals yet. But the kid is anxious and confused. So we think he's probably like here, right? Class 3, which is quite a bit of blood loss. He's probably pretty tachycardic once you get some vitals. He may have a bit of a decreased blood pressure. Yeah, pretty sick, right? And even though this kid is losing blood and not salt water, right? Starting fluids is certainly reasonable on him to kind of pump up that volume a little bit. There's certainly a lot of controversy about that. But if you have no blood on scene and the helicopter is going to take a while to get there, definitely a reasonable approach once you've stopped the bleeding. And then kids usually, do well with fluids. They're more fluid responsive. Certainly when they're bleeding, you want to give blood, but in general, kids do a little bit better with fluids than adults and tend to kind of respond a little bit better to that. We'll talk a little bit more about that later. All right. Second kid. This is the 8-year-old. Cerebral perfusion. Oh, yes. Permissive hypotension. The age-old. Exactly, Steve. The 8-year-old was extricated by your local friendly fire department on a scoop. He says his neck hurts. He's sitting in the scoop. He's keeping his head very still. His airway is intact. He has equal chest rise bilaterally. He's actually breathing quite comfortably. He's not bleeding from anywhere. You think he's pretty well perfused. He's awake. His pupils are okay. You don't see any external signs of trauma. What do you think? Do you put a collar on this kid, a C-collar? Yeah, you do. Exactly. What if, let's say you're trying to put the C-collar on and he starts crying and flailing and moving his head? What do? Do you force it? Is there anything else you can do? Blocks, yep. And how do you transport this kid? Towel rolls. Remember their heads. Their heads are big. So we're talking about C-spine injuries in kids, right? And how they occur higher up. Horseshoe collar with blanket. Yep, I like that. They occur higher up in the cervical spine, right? So more in like the C2, C3 level versus the C5, C6 in adults. Their heads are bigger, they lead with their heads. They're, prone to kind of damage that area on their necks. There's two main goals in immobilization in general, right? Not just in pediatrics, but in general. You want to limit the current damage and you want to prevent any secondary injury from that damage, right? Remember that immobilizing a C-collar does not really effectively stabilize the entire spine. It just stabilizes those couple of areas, right? The way you really stabilize their entire spine is to kind of get all of the spine and the weight center aligned, right, in a neutral position. When we're talking about kids, the goals of immobilizing are pretty simple, pretty similar. You want to maintain that neutral inline position, and you want to control the weight centers, which for kids are their head, their shoulders, and their pelvis, right? So like Becky said, you want to pad things as needed for the big head. So you want to provide padding to have that like neutral inline, neutral spine position. So you want to put, padding here, a little bit of additional padding under the shoulders to kind of get that head. So the rest of the body is lifted up and the head lies in this neutral position. A vac mat is also a great way to do this. Exactly. Really, any strategy that accomplishes this is a good idea. As long as also the kid is comfortable, right? Because if they're uncomfortable and flailing around, they're going to cause more potential damage than if they're comfortable and keeping themselves still. Using a long spine board, like an adult one, is not great, but if you have padding, if you have like a vacuum mattress, you have something to make them comfortable, then it's totally acceptable and it's a very reasonable way to transport this child. Usually like 2 to 4 centimeters of padding is what you want to do to kind of really lift that head, but you want to kind of eyeball it and see where their head is in a neutral position. And then its shoulders is good, but you also remember you need to kind of pad the rest of it, because if you just pad the shoulders, then their like thoracic spine will kind of be all cattywampus, and you never know what kind of injuries they had. And then the padding wise, if you have them like on a scoop or something, padding on the sides too, to keep them from kind of wiggling around is also more comfortable, and also prevent some lateral shifting. Really, whatever the most comfortable way is a good way to do it. All right. Some cautious analgesia. Yes, cautious analgesia. Very politically correct of you, Steve. Definitely treat pain, absolutely, to keep the kid comfortable. All right. Next case, or excuse me, same case, next patient. 15-year-old was ejected. Airway, sonorous respirations, they're tachypnic, absent right lung sounds. You don't see any bleeding, but the pulses are thready, unresponsive, pupils are okay. And then you see like abrasions, ecchymoses everywhere, including the chest wall. What do you do? This kid is sick, right? Does this kid need an airway? Yeah, definitely sounds like it, right? How do you do that? What's your first move? Make his respirations not sonorous. Exactly. Sick, possible pneumo. Remember, in kids in general, and really in all patients, depending on resources, but BLS airway is our first go-to, right? So in this patient with the significant trauma, yeah, you want to do a jaw thrust. Exactly. You don't want to do it head tilt chin lift, of course, because you want to protect the C-spine. And then, yeah, this kid is probably going to need an eye gel. I don't think if the jaw thrust fixes things, changes things, great, but you're probably going to need a more definitive airway. And an eye gel versus intubation is usually vastly preferred in pediatrics. And then those thready pulses, no right lung sounds, like you already identified, probably needs a needle, right? Because he has a pneumothorax. The big takeaway from this patient is not necessarily that to talk about specific individual management, although, you guys have great ideas, decompress and everything else, but it's really to talk about like resource utilization, right? This is the kid that you're probably going to fly out first. If he's not quite a expectant patient, right? We still have pulses, we still have everything else. So this is the kid you fly out first because he is certainly the sickest. All right, and then you have the driver. You have the 16-year-old who says he's fine. He got out of the car himself. Airways intact, breath sounds are equal, not labored, well perfused, GCS 15, he's walking around. He has a scalp abrasion and he's like holding his wrist, maybe looks a little deformed. But that's about it. He wants to refuse evaluation and transport. What do you guys think about that? Can he? Nope. Minor, exactly. No refusal. Unless emancipated. Exactly. So first question, right? Patient or no patient? And this is our protocols, but a lot of protocols in Colorado, but I'm imagining, a lot of other places have something similar. But if he's under 18, he's a minor, he's automatically a patient. Yep. And then the other thing exactly is even if he wasn't, that mechanism of illness, my goodness, yeah, he's definitely a patient. So step number one, patient, yes. Step number two, can he refuse care, right? He can't really. This is still our protocols, but he's a minor, and unless he's emancipated, he can't make really that decision. And so you need base contact, right? Less than 18, unless the parent or guardian is on scene, is a high-risk refusal. He's a high-risk patient just for mechanism of injury itself, but high-risk refusal would definitely get base contact and have someone try to talk to him, etc. This is not someone you would just sign out AMA. What about like his Uncle Bob shows up? Can Uncle Bob refuse care if he's not the kid's guardian? Just like Uncle Bob down the street? Yeah, no, he can't. Would still do base contact, exactly, because you need a legal guardian. Certainly if the kid wasn't injured and it was something way less severe, right? So fell and tripped and someone called 911 and he has no injuries, then it may be reasonable to leave with an adult who can guarantee that he'll get him to his family or whatever. But with this mechanism of injury, definitely a very high risk. And then now you're thinking, crap, did I just have consent to treat those pediatric patients? Should I have called their parents or legal guardians? No, of course not, right? This is the concept of implied consent. And this sentence specifically is from the American College of Emergency Physicians. So it's specifically geared towards hospitals and emergency departments and refers to EMTALA. But the implied consent basic concept certainly applies to EMS as well. So if an emergency medical condition is discovered and you can't get consent, family's not on scene, you're not gonna certainly call them, especially with that 15-year-old with sonorous respirations, then must provide treatment, stabilization, and transfer, right? This is the emergency exception rule or the doctrine of implied consent, which basically says if a guardian was there, they would consent for treatment because this is in the best interest of the child. If it's not emergency, then it's a little bit different, but this is emergency implied consent, and absolutely doing the best thing for the patient is the right move, even if you can't explicitly get a guardian's consent. Any questions on that case before we jump into the next one? Sorry to start with such a serious and sad case. Just good conversation. All right. Case 2. You were dispatched for a 14-month-old with altered mental status. What are you thinking about when you hear this? What are you kind of preparing for on the way? What are you getting ready, whether physically or mentally? Want to make sure you have blood glucose versus seizure. Okay. Trauma, oxygen, yep. Peds kit, right? Where's that kit with all the things? Got to find it. Got to remind yourself what's in it, right? Haven't opened it in like 9 months. Yeah, exactly. So we get a little bit more information. You get on scene. You see a kid, airways intact, breathing is not labored. It's a little sweaty, a little diaphoretic, definitely not responding, but no trauma. And mom tells you he's otherwise healthy. He was briefly unsupervised this morning, maybe for like 15 minutes. Mom had to like run to the grocery store. And then was last seen normal just about 30 minutes ago, was put down for a nap. And now she can't get him to wake up. In the house, just lives in the house with his grandparents and the mom. You don't see anything concerning. What are you thinking? What's the next thing you really want to make sure you have on this patient? What piece of information or data? Unresponsive, sweaty kid. Blood glucose. Exactly. Or a fever. Yeah. So his heart rate's 100. His temperatures, or excuse me, his respiratory rate's about 22. Temp's normal. Blood pressure's 90/50, which is normal. And then satting fine. And then his glucose is 42. Why in the world is a 14-month-old hypoglycemic? Took pills. I can't fool you guys. Yeah. So mom's healthy. Grandma has hypertension, AFib, and diabetes. And grandpa has Parkinson's and depression. Whose medication did he get into? Anybody's, right? Probably grandma's. Thank you, Steve, for the colorful commentary. Yeah, he got into someone's medication, right? You see this on the counter. 14-month-old crawling. This is a very dramatic title, but it is very accurate. It's also called One Pill Can Kill. It's this list of medications that with a kid's weight less than 15 kilos, one pill of the regular dosing can really have quite drastic effects. If a toddler who weighs like 10 to 15 kilos gets into it, can really have disastrous consequences. These are a lot of the medications. It's not all of the medications, but it is some of the most common ones. So the cardiac drugs, your calcium channel blockers, right? Amlodipine, nifedipine, verapamil, diltiazem, clonidine, your alpha-2 agonists, Parkinson's drug. So legiline is like a monoamine oxidase inhibitor. So Parkinson's drug. The tricyclic antidepressants, the TCAs here, the amitriptyline, the imipramine, and then certainly the benzos can have a big effect as well. And then the diabetic meds. And specifically, this kid got into, a sulfonylurea. So there's a couple of the brand names here: gliclazide, glimepiride, glipizide, and glyburide. Try to remember all of those. But that's what the toddler got into. Sulfonylurea is a diabetes medication that, take away from all this, don't look at this. This is just pretty and colorful. But it basically stimulates the release of insulin from pancreatic cells. And it also increases insulin sensitivity. So basically, if you're not diabetic, it can really drop your blood sugar. I mean, you can do in diabetics too, but especially if you're not diabetic, one pill can really lead to hypoglycemia. Tends to peak around 4 to 8 hours. Onset of hypoglycemia is around 8 hours, right? So this kid was unsupervised this morning, got into some pills, 6 to 8 hours later, he's not responding and hypoglycemic. The tricky part about these medications is they have a really long half-life. So they can hang around and cause low blood sugar for quite a while, sometimes even days. And it can be really profound hypoglycemia. So like really, really low blood sugars. These medications are wonderful for diabetes, can definitely be dangerous if accidentally gotten into. So what do we do, right? Sugar water. For pediatrics, yep, D10, exactly. Remember, we can't do D50 under certain weights. If you have D50, you can always kind of do a little dilution thing, but you basically want to do a 2 mil per kg, 10% dextrose, and you want to check the blood sugar, and you can repeat it if needed, right? For prolonged transport specifically, if you're out in 30 minutes to your closest hospital, you definitely want to treat, repeat again, a couple minutes later, repeat the glucose again, kind of really keep a close eye on this, because like I said, it can have some really profound hypoglycemia and can last a really long time. Don't just treat it once and call it good and then kind of like, play crossword puzzle on the way in. This is definitely a patient that you want to keep a very close eye on. In the hospital, there is an antidote that we can give, and it's a medication called octreotide. Basically, what happens is, someone takes this medication, you give them some dextrose. In a normal functioning pancreas, when you get dextrose, then insulin is going to release because that's what your pancreas does. So it can, again, lead to hypoglycemia, rebound hypoglycemia. So what octreotide does is suppress the secretion of a bunch of hormones, including insulin, so it prevents that rebound hypoglycemia from happening. And you put these folks on an infusion until you get their kind of until they ride out the effects of the medication. These folks will be watched for a long time, like 18 to 24 hours at least. For adults, usually like shorter, maybe 8 to 12, because adults, can eat, be more in control of themselves. But they definitely need to be observed, and it's for a long time, and these kids are getting observation status or admission at the least. And you guys totally got it, but just remember, once kids start walking, they try to get into everything, and can include family members' medications. So, make sure you ask about meds in the home and like bring a list if possible when you're transporting. Glucagon is one of the things we do as well. I am not a toxicologist, so I would consult my local Rocky Mountain Poison Center, my local toxicologist, but I have seen that touted as a potential treatment for this as well. So yes, glucagon can certainly also work. Any questions before the next case? All right. Now you have a 5-year-old with altered mental status. Seeing a theme here. Airways intact when you get on scene. Increased respiratory rate though. Kind of looks like he's breathing a bit. Pretty rapid pulse. Cap refills, a little bit delayed. Looks kind of tired. No trauma. Mom says, he's healthy, but he's been unwell for a while. A couple days, maybe a week, maybe a little bit longer. And today, she couldn't get him up. She did finally, but it took a lot to get him up. He's been really tired and weak. He's been eating and drinking well, but maybe even more than usual, but somehow he's losing weight. Does this make you think of anything? Yeah, you want a glucose, huh? So heart rate's 170. Sepsis, definitely on the differential. Respiratory rate's 36, right? Clicking off all the STARS criteria there. Temp is borderline, 90-94. Blood pressure, quite low, 76/50. That's low for a 5-year-old. He's setting okay, though. Somebody who said blood glucose, you get that. And it says high. What's going on with this kid? Type 1 diabetic, yeah. Hyperosmolar HN, yep, the HHN and HSMSK situation, yep, or DKA, exactly. So this is diabetic ketoacidosis. And just as a refresher, this is a complication of type 1, sometimes type 2, mostly type 1 diabetes. Remember, in diabetes, like we talked about, it's either that your pancreas doesn't make insulin or your body just has a resistance to insulin and doesn't use it very well. The point of insulin, right, is one of the big things it does is to lower your blood glucose, your sugar in your blood. So when you have DKA or diabetic ketoacidosis, there's a severe deficiency of insulin. So you don't have any insulin. So your whole metabolism of proteins and carbs and everything else gets really disordered. And so your blood glucose is super elevated. And because there's no insulin, which helps introduce it into the cells, it's not going into the cells. So it's all staying into your blood. Because of that, your body goes into this fasting state, which means it's using because it's not using the glucose, right? It can't accept the glucose into the cells. So it's using this, it's breaking down protein and fat for metabolism, which leads to ketosis and ketoacidosis. The diagnosis officially, according to the International Society for Pediatric and Adolescent Diabetes, you have these 3 components, right? You have hyperglycemia, so blood glucose greater than 200. You have ketosis, so you have ketones either in your blood or urine, whichever you measure. And then you have a metabolic acidosis, right? Makes sense. Diabetic ketoacidosis. That's nice, but don't have that in the back of an ambulance, right? We only have access to the glucose. So how do we suspect this pre-hospital? What are some clues? Really understanding what insulin deficiency does is kind of how we kind of understand this whole presentation. So insulin goes down, blood glucose goes up, right? Cells can't take in the glucose, so there's a bunch of glucose in the blood. When there's a bunch of glucose in the blood, then the blood, the plasma, is hyperosmolar. So it's super concentrated, basically, right? So then when that gets to the kidneys and it's super concentrated there, it draws a whole bunch of water into the kidneys and a whole bunch of electrolytes because it's concentrated. Water goes where it's concentrated to make it equal. So then you lose a whole bunch of fluid, right, through the urine, through this like kind of osmotic diuretic effect. So then you have polyuria, so you're peeing a lot, increased urination. And because you're losing so much water, you're pretty dry, so you're also getting increased thirst or polydipsia. If this is unchecked and kind of continues, then you're going to have pretty severe dehydration. On average, yep, IV access fluid, exactly. On average, a adult, let's say, with DKA is like 4 to 6 liters down. We've kind of turned back a little bit recently, are doing more like 2 to 4 liters, but really has a big fluid deficit is the whole point. And then not only does this kind of, diuretic effect make you lose water, but it also makes you lose electrolytes, so potassium and phosphorus and all that other stuff. So that's dehydration. 1 keto acid, which is acetone, can sometimes be smelled, and some people can smell it, some can't. I walk into the room, I can smell DKA from 5 feet away. Some people can be all the way up by the patient and can't smell it. Just depends on what like receptors you have, but that's the fruity odor that we talk about with DKA. Because you're acidotic, patients are trying to compensate, right? So they want to blow off that CO2. So they try to take these really deep and labored breaths, right? So really deep and fast to blow it off. And so you can also sometimes see Kussmaul respirations, which are these like classic pattern that you see with diabetic ketoacidosis, just fast and deep breathing, abnormal breathing. And then for some reason, it's not really clear entirely like the mechanism of it, but acidosis can also lead to abdominal pain. A really common presenting symptom of patients with DKA is abdominal pain. But remember, don't dismiss it. Keep thinking about all the other things that could be going on, right? Did they have appendicitis that then triggered their DKA, or is this just belly pain because of their DKA? Keep a high index of suspicion. And then there's something specifically in kids that's a pretty rare but quite lethal complication of DKA, especially if they're treated with like bicarb. But it's called cerebral edema, and it's like less than 1%. So again, very, very rare, but it has a mortality rate of like half. Not really clear. It has something to do with the severity of the acidosis and kind of with the fluid shifts and everything. But basically what you'd expect with increased intracranial pressure. So you have headaches, you have vision changes, altered mental status, etc. And then think about the trigger, right? It has to be a trigger for the DKA. This kid didn't know he had diabetes, and this was his first presentation, but and can certainly trigger, something like this can trigger it. But then, even in a patient who has diabetes, think about like what pushed them over the edge. Is it that they just weren't taking their meds? They weren't complying with their diet? They weren't doing their insulin? Do they have an infection? That's one of the most common causes or triggers, like urinary, respiratory, skin. Doesn't matter. Infection throws your whole thing off balance. Is there an infarction of some kind? Less likely in pediatrics, but certainly like a myocardial infarction in an adult with diabetes can certainly trigger DKA. And then pregnancy can too. Even a normally well-controlled diabetic patient who gets pregnant can go into DKA. So remember to think about the possible triggers and address those as well. Pre-hospital treatment, you guys already nailed it. IV access and fluids, saline. Usually we do about a 10 to 20 cc bolus, cc per kg bolus. And then, so, like starting that is great pre-hospital. And then based on cardiovascular status, especially with prolonged transport, can certainly consider additional boluses. Once we know the potassium, we'll also give insulin. And that's why we don't do insulin pre-hospital for this, right? Because we don't know the potassium. The reason is because when you give insulin, the potassium will be driven into the cells. And so even if your potassium level looks normal, if it's driven into the cells, it can become really low in the circulating volume, and then you can have some nasty hypokalemia complications. So we always check a potassium level in the hospital before we start insulin to treat this. From an extended transport time, you may end up giving like the entire bolus and then some, right? But remember, kids can tolerate fluids. They probably have they have a higher cardiac reserve, like we talked about. So they can compensate for volume loss much longer than adults. And they may have like pretty almost appropriate vital signs, right, for age, despite having a lot of fluid losses. So by the time they're showing any signs like tachycardia and low blood pressure, they've probably lost a lot of fluids and they have a lot of room to go. They're less likely to fluid overload because they have healthier hearts and, just generally healthier, ideally in a healthy kid. But you certainly still need to watch for it if you're giving a bunch of fluids to a kid, especially in infants. And then, prolonged transport, watch that mental status, of course, as you would with anybody with ultra mental status, but certainly to look for that cerebral edema that we were talking about, any like confusion, headache, anything like that, vomiting, certainly be concerned for that. And then, like, am I making diagnosis of type 1 diabetes like in the field for the first time in a kid? You might be, because type 1 diabetes, a lot of the time, like 30 to 40% of the time, will present with DKA at the time they're diagnosed. In the US and Canada specifically. They may have no idea, right, if they have diabetes, or the mom has no idea when they're calling 911. Some factors that increase the risk of this, meaning that they will present with DKA at the time they're diagnosed, is if they're younger, less than 5, especially less than 2. A lot of the time they'll present with like respiratory issues, and they'll be like, oh, it's bronchiolitis or something, or bronchitis, and not check the glucose, not check labs, and kind of miss this diagnosis. Certainly low socioeconomic status and reduced access to medical care is a big risk factor for not having your diabetes diagnosed until you present with DKA. And then living in places that have low prevalence, which in the US, I don't think too many of them exist, but can certainly cause somebody to miss the diagnosis. There's 2 peaks of like presentation or diagnosis really of type 1 diabetes in kids, and that's 4 to 7 and then 10 to 14. So those are the big 2 noticeable peaks. And remember the history where you might get this in an adult with the drinking more water, peeing more, weight loss, etc. You may not get any of that in a toddler or a 4-year-old, and so it's easy to for healthcare people to miss this. So just have a high clinical suspicion. Any questions on that? All right. You're dispatched to a 14-month-old with ultra mental status. You're thinking, another one? Yes, another one. Airways intact, non-labored, warm and well perfused, alert, kind of looking around. No trauma though. Dad says that kid was in the back of the car, appropriately strapped while dad was driving, heard some gurgling, saw the kid kind of looking off to the side, maybe doing a little shaking, looking off into space, blue lips, pulled over. By the time he got out of the car, that activity had stopped, but now was acting sleepy and confused, maybe slowly getting better, but not entirely like back to normal. No recent illnesses, no injuries, nothing like this has ever happened before. This isn't really a diagnostic dilemma. Ooh, choking. I was gonna do a choking case, but seizure, aspiration, cardiovascular, hypoxia versus seizure. Yes, love this. A little bit more info. So heart rate's 170, respiratory rate's 36, temp is 100.5, a little bit of a fever. Blood pressure is normal, oxygen's fine, so not hypoxic. Glucose is fine. What are you thinking now with that little touch of fever there? Definitely a seizure, right? Maybe a febrile seizure. So sounds to me, right? Like she had a seizure and now she's post-ictal, like a lot of you guys identified. Just as a reminder, a couple types of seizures. There's generalized, where just kind of the tonic, clonic, loss of consciousness, ultramental status, etc. And then there's partial or focal, which just involves a side of your brain and tends to have maybe just one side of the body involved. And then there's absence seizures, which are those staring spells. I'm sure there's a lot more nuanced. categories, but I'm not a neurologist, so that is how I think about it. Seizures can be provoked or unprovoked. Provoked is the result of a temporary event, right? So low blood sugar, you have fever, you have meningitis, maybe head trauma. If it's unprovoked, then you have no known or identifiable cause, and that's when we kind of, lead towards epilepsy. The stages, right? You get the aura stage, kind of that confusion, maybe dizzy, kind of weird aura stage. And then if it's a generalized tonic-clonic, you get the tonic stage, which is the stiff body, incontinence maybe, and then the clonic stage, which is the jerky movements with the frothy saliva, the gurgling, and then afterwards you're postictal, where you're kind of sleepy, exhausted, and kind of weak. Status epilepticus, as a brief reminder of the criteria for it. We used to call it one thing, which was, we used to say if it's more than 30 minutes of seizure, or if you've had 2 or more seizures in 30 minutes. 30 minutes of seizures is a lot. Now we're saying if it's greater than 5 minutes, or if it's recurrent without you fully returning back to baseline in between. So you have 2 seizures and you don't return back to baseline. That's technically considered status epilepticus. This patient just had a regular fever, specifically a febrile seizure. This accounts for the majority of seizures in pediatric patients, and it happens to like anywhere from 2 to 5% of kids. Usually ages are like 6 months to 6 years. They peak in that 12-month to 18-month time frame. So this patient was the perfect age for that. And about a third of the kids who have a febrile seizure ever will have another febrile seizure at some point. Giving antipyretics, so ibuprofen or Tylenol, what have you, does not decrease the risk of recurrence, but certainly helps the kid feel better. 2 main categories of febrile seizures: one that we don't worry about as much, which is simple, and one we worry about a little bit more, which is complex. So simple, it has to be, for it to be a simple febrile seizure, it has to be a generalized tonic-clonic, so that whole description earlier with the tonic and then shaking activity. It can't be partial. It has to last less than 10 minutes, and it can't happen again within 24 hours. This has about a 1 to 2% of the kid developing epilepsy later on down the road, which is about equal to the general population. So it does not increase your risk of developing epilepsy. Complex, on the other hand, we worry about a bit more. They're focal, so only one side of the body, one hand, whatever. They last more than 10 minutes, or they happen again within 24 hours. If any of those criteria are met, then kid has about a 5 to 10% risk of developing epilepsy later on. So a little bit more of a concerning picture. So what do we do pre-hospital, right? By the time you get there, seizure stopped, most likely, unless they're super sick. Antipyretics, if you have them, definitely worth giving. So Tylenol, ibuprofen, whatever you have, depending on age, of course, if it's age appropriate. But really, it's just for the child's comfort, to make them feel less crummy from whatever's causing their fever, more so than to have any effect on future seizures. Definitely ABC, supportive care. Make sure you have, padding in case they seize again, and all that good general seizure care. And even if they return back to baseline and they meet all the criteria for simple, it doesn't matter. They should still be evaluated. We got to make sure we're not missing meningitis or some other serious bacterial infection that happened to present with a seizure. So definitely kids need to get evaluated. We kind of had thrown out some other stuff, but while we're talking about altered mental status for pediatric, what else are you guys thinking about? We talked about trauma. We talked about sugar, whether high or low. We talked about seizures. What else? Steve mentioned hypoxia. What else do you think about for a kid who's altered? What else could they have gotten into? Poison, allergens. Maybe some infection-y stuff too, right? Like we already talked about, meningitis, sepsis. Someone mentioned sepsis. Other tox stuff, right? Did they get into the fridge and drink a beer for 14-month-old? It's a lot of alcohol. They could be pretty altered. Are they 15 and took some Molly with their friends, right? Other tox stuff. Do they, for some reason, have an intracranial bleed, right? Is there a family history of aneurysms? And they, you know, had one break and have a subarachnoid hemorrhage or something like that. Abuse, yep, absolutely. I did not put a case like that in there. I feel like it's in every pediatric presentation I've ever seen, but absolutely you have to have a very high index of suspicion for non-accidental trauma. Definitely. All right. Case 5. You have a 2-year-old with a burn. You get on scene, airway's intact, kid is crying, no respiratory distress. Rapid pulse, cap refilled, slightly delayed. Looks a little tired. And you see burns, blistering burns to the hand, the chest, the abdomen, and the tops of both feet. Dad says he took a hot liquid dish out of the oven, turned around, and the patient had pulled it onto herself. Not really a big diagnostic dilemma here, but what are you looking for on assessment? What are the main things you want to establish for a burn to figure out where you're going and what you're doing? Consistent pattern, yep, is it consistent with the story? This is supposed to be. Pulled it kind of on top of themselves, onto their hand and everything else, yep. What are some things we talk about with burns when we're thinking about, oh, does this need a burn center or that kind of stuff? This does, yes, this does. Body surface area, exactly. And then the degree too, right? So burn assessment in general, how you kind of approach, right? So you want to determine the total body surface area and you want to determine the degree of burn. Because if it's 1st degree, nobody really minds as much. But if it's anything worse, then you have to think about that. Inhalation injury. Was this a fire, right? Do you have to worry about their airway? This wasn't. This was, some hot soup or whatever. But definitely something to think about. And then if you're worried about a burn with inhalation injury, you have to think about carbon monoxide. I know my fire folks out there do. And then don't forget to assess for trauma, specifically in a fire building kind of situation, but trauma will always take precedence over burn in terms of immediacy of management. So if this is, did the kid pull the heavy dish onto their head or something, right? Or if it's in a fire situation, did they actually fall off the 2nd floor as they were trying to escape the fire? So those are the big kind of pillars of burn assessment. This is kind of a breakdown of age in months and what their incidence of being exposed to certain things that burn them are. So, definitely in that like toddler, 20-month-old to like the, 5-year-old is when a lot of these things happen, whether it's fire or scalding object or touching a hot object, right? Moving around and touching things on the stove. And then electrical, want to stick something metal into the socket. This is kind of that peak age for kids to get in trouble. Brief review of the degree of burns. So we don't really call them 1st, 2nd, and 3rd or 4th anymore. We call them with the thickness and stuff, but I think, either one is still acceptable. It is a, language that people understand. Remember, the 1st degree or the superficial thickness is just the epidermis. So just the top layer of skin. It's painful. It's like a sunburn, right? It's painful, but it's not bad enough of a sunburn or other burn to blister, and it won't scar. So that's the least amount of burn. When you're talking about the 2nd degree, you're talking about it's moving into the into the dermis, which is the underneath layer of the skin. And then it kind of depends on how deeply down it goes, right? If it's superficial, partial, then they don't require surgery. They may scar, may be painful. The deeper down it gets, this will definitely require surgery. And this is going to be actually a little bit less painful because here's where all the nerves live. So once you burn down into that, you're not going to have as much pain. 2nd degree in general tend to blister and they tend to weep. And then definitely worry about infection and scarring the deeper down it goes. And then 3rd degree, this is, all the way through the dermis. This is dry, so it's not blistery and weepy, it's dry. It's insensate, so it doesn't hurt. And and small areas, you know, are going to heal, or excuse me, these are going to heal with like scar contracture. If it's really large, you're going to need a skin graft. These have pretty high risks of infection. And then 4th degree is all the way down to the muscle and bone. It's a horrible burn. And then the total body surface area is the other thing we have to figure out. There's a lot of ways to estimate. I think there's like 8 or 9 different scales that I found for how to estimate a total body surface area. And the real talk is we're bad at it. You guys are bad pre-hospital, and you know, we're bad in the emergency department. Like, you know, we kind of tend to overestimate, which isn't a bad thing necessarily. Burn will always like come down and be like, that's not 10%, that's 3, you know. Usually the rule of 9s is what we use, and which is a little bit different for a kid because of their head. Like I said, it has more surface area. This is the Lund-Browder burn diagram, so helpful with adults and children. And then it kind of tells you what their head is based on their age. So if they're 1-year-old, then the head counts for 19%, but then by the time they get to 15, it's only 9%, or, you know, 11% when they're 10. So a lot of different ways to estimate. A good rule of thumb, which you guys know, is 1% is the patient's palmar surface, including the fingers. So you can use that, whatever your preferred method is. And then remember, like I said, the surface area distribution changes with age. So as the head gets smaller and everything else kind of catches up, proportionally speaking, then it's going to be less of a surface area. And what do we do for burns pre-hospital? Well, you definitely want to remove any clothing, jewelry, you know, debris if there is, gently, of course. You may want to try to cool the burn if it's something like this and you get there just in time. Chances are, if it's a kiddo who pulled something hot on themselves, you know, their guardians or parents have already run them under the water for a little bit. But you don't want to do this for a long time. It's just like, you know, less than 5 minutes because you don't want to macerate the wound. You can also do, if you don't have running water, some wet, clean gauze or towels that can be left on for a little bit longer, and that can help kind of cool. Then you want to dress it. This is just for partial full thickness. You don't need to do this for superficial, certainly. You can do non-adherent gauze like Adaptic or Zeroform if you have it, and then a second layer with dry gauze, and then kind of wrap it with a roll and some Curlex. But if you don't have it, dry non-stick gauze is the way to go. We used to do moist dressings. We don't do that because for several reasons. It increases the risk of hypothermia because, as you guys know, when your skin is burnt, you don't have that protective mechanism to maintain your temperature, excuse me. And so you lose a lot of heat through that area. And then these moist dressings can also really macerate the wound, really make it worse. So we're not doing that anymore. And then, as has already been mentioned for the C-spine kid, pain management. Cannot emphasize that enough. And especially if it's a prolonged transport, there may need redosing, right? So be kind to your burn patients, treat them with plenty of pain medication. And then fluid, how much fluid are we doing? There's so many different formulas out there, just like there are for estimating. But the most widely used and accepted is the modified Parkland. So not the OG Parkland, but the modified. And you use this if there's more than 10 to 15 total body surface area. So this kid met it with all of the burns that he had. But this is when you kind of start thinking about fluid losses through the open skin, and when you have to start thinking about replacing that fluid. They're saying 2 to 4 mLs per kg, and then multiply that by the percentage of the total body surface area. And then, you know, the classic half of the volume in the first 8 hours, second half over the next 16 hours. And then when they get beyond that, they'll continue IV fluids. In kids less than 2, often we'll add like some dextrose, like D10 or something, if they're less than 2 or less than 20 kilos, to avoid hypoglycemia from all of those fluids. Eventually, the patient has to go to a burn center, right? Pediatric, there's like some referral criteria from the American Burn Association for when a patient has to go to a specialty burn center. And pediatric is always one of them. If it involves joints, if it involves a certain amount of percentage of area, just review your protocols for that. I'm sure they're written in there somewhere. But yeah, and that's pretty much burns. I talk fast, so I am done. What questions do you guys have? And as a reminder, I'm going to put Ryan's email in there again for CE. Questions, comments, concerns. Start my video again now. That's yeah, absolutely. Awesome. I'm going to stop recording, but I'll hang around in case you guys have any lingering questions. Otherwise,